So we've got 3 sessions coming up, and first off we've got James Tooley, and he's got so many titles I've written them down so I don't forget them all. So first off, he's clinical lead for NEST, which is Neonatal Emergency Stabilisation and Transfer Team. He's also a consultant with WATCH, which is the Wales and West Acute Transfer for Children, and he's a HEMS doctor, and he's going to be telling us about 5 papers in neonatology.
Well, thank you very much for coming. Now, obviously, if this was a neonatal conference, I'd probably choose 5 slightly different papers. So what I'm trying to do is to choose 5 papers that I think will be helpful for guys who don't do neonatology every day. And I suppose, in essence, that is 5 papers you don't have time to either go and Google or read before you see a patient. So they are, in essence, 5 papers mainly about resuscitation. Now, some people are in this room because they think I'm going to show loads of cute baby pictures. Well, I'm sorry, this is it. But some people are here because whenever they get involved in a neonatal patient, things just fall apart. Literally not the baby, but things around them fall apart. So I know some of you like a good story. If you don't like a good story, I'm going to tell you 5 papers about resuscitation, so that's all you have to remember, yeah? But the story starts actually 22 years ago when I was a registrar. I know I don't look that old, but 22 years ago I was a registrar in the east of England, and I had the cardiac arrest bleep on. It went off saying, "Can you go to adult ED?" And I thought, good, a mistake. And then carried on doing what I was doing. 30 seconds later, "You need to come to adult ED now." And I felt like I said, "What's going on?" They said, well, we've got this woman, isn't it? I go, "Oh, good. Yeah, woman, I don't do those. I am a neonatologist." They said, "Oh, she's pregnant." I said, well, even better. Send a delivery suite. And they said, "She's in cardiac arrest." I thought, oh, shit. So anyway, we all ran down to delivery suite. And unfortunately, she'd been hit by a car and was in cardiac arrest. So she walks in the door, and the team are doing CPR. She's been intubated. Paramedics are kind of, running around. Everyone is just loads and loads of action. I'm standing there, and the obstetrician's next to me, and we sort of stood there for a bit saying, "What are we supposed to be doing here?" And he said, "I don't know. Well, what should we do about the baby?" So, I suppose if you don't cut it out, it's definitely going to die. And if you do cut it out, it'll probably die, but that's the only chance, really. He said, "Okay, I'll go and do that then." So I turned around and realised we hadn't brought any kit with us at all, and it was adult ED. Looked around and thought, well, what space am I going to use? And I started getting things ready, and I turned around and the baby was there. He literally cut it out in about 30 seconds to 60 seconds. So we're faced with this baby. And that's what he did, a very rapid perimortem C-section resuscitative hysterotomy. So if you're in the adult world, you'll know about this, but I suppose why am I presenting? This is my first paper, and it's about a framework for how you undertake perimortem C-section. This is mainly for pre-hospital doctors. This comes from the Faculty of Pre-Hospital Care, which is based at the Royal College of Surgeons. But if you work in adult ED, you'll know this as well. So in essence, if an adult woman of pregnant-bearing age goes into cardiac arrest, you need to cut the baby out. And I'm just telling the paediatricians in the audience, you're not cutting the baby out for the baby. You're cutting the baby out to save the woman's life. But if the baby comes out, you should at least do something with it. Yeah? So, and I have to say, I've been to a few of the air ambulance bases around the UK, and many of them have an SOP which stops with cutting the baby out. And then, I'd go along and I'd go, "Oh yeah, what do you do with the baby?" I said, "Well, I haven't really thought about that." Because it's all about getting a return of circulation in the woman. So all I want you to do is to know this exists. At the moment, you may have only really been exposed to it if this happened in your own ED, but increasingly you're going to have the pre-hospital teams who are trained to do this. They get regular training about this. They, just like Annie Weaver's talking about the thoracotomy, the pre-hospital teams are taught and regularly trained to do a perimortem C-section. So you are going to have a baby delivered to your hospital. And I don't know, I cannot tell you whether that baby will arrive in adult ED with the mum, into children's ED, or to delivery suite. And I think you have to go to your own departments and work out how that's going to happen. Anyway, so just want you to know there's this framework. Please have a read of it, see what you think. In essence, what does it say? It says if you're pregnant, your bump comes up to your umbilicus, then after 4 minutes, within 4 minutes, you need to start thinking about taking the baby out and actually start the process. So really quick reversible causes. What can I do? Do we put a tube down? Do we oxygenate? What's the cause? Okay, let's cut the baby out. And that should be done starting at 4 minutes and completed within 5. Now, recently, so since we've been teaching this, since we've been seeing it in action, And it's obviously much more successful pre-hospitally now. You can imagine if you had to wait for a pregnant woman to be brought from home to ED, an obstetrician to get there and cut the baby, we're talking 20, 25, 30-minute delays. Now that we're doing this pre-hospitally, people get up to 15 minutes to do. So in our minds, we're thinking, is this between 5 and 15? We might have a likelihood of actually either saving the woman's life or the baby's life. Now, I hope my wife doesn't look at my Google history, because I downloaded these. And the reason I did that is because I think you need to have an idea about what we're talking about, 20 weeks. So the guideline is, if your bump is up to your umbilicus, that's when you've got to cut the baby out. And that's about 20 weeks pregnant. So, I mean, I think you have to be a bit careful, because, you know, there certainly has been 1 or 2 pre-hospital resuscitive hysterectomies where actually the woman was just a bit chubby, it wasn't pregnant at all. So just so you need to know that they're pregnant, really, or have a heavy assumption that they're pregnant. But this is the size we're talking about. This is the guideline. You need to train for it. That's the only thing I'm going to say about it more. The link will be in the papers. Just have a think about that. So moving on from that, this obviously leads to a very unpredictable resuscitation. You weren't ready for it. I mean, you know, that top one came off Google. I don't know whatever's going on there. This looks like some baby that's died in the middle of the street. And obviously, we don't advocate this form of resuscitation down the right-hand side there. But in essence, you are not going to be as prepared as you want to be. The cornerstone of neonatal resuscitation, once you've done a bit of fiddling around, is actually the kids all get intubated. And actually, that's quite different now to adult medicine. I get to lots of adult cardiac arrests, and because of the Airways 2 study, we use a lot of laryngeal masks, for example. But nearly all babies end up being intubated at some point. And I'd like to say we're good at it, and I think Beth's going to try and get us good at it later. But I think you have to know the first pass success rate of intubation is about 50%. So neonatology is not particularly good at getting a tube in. What you'd really hope is you get this perfect view, you know, grade 1 view, top left. But that's not what normally happens. Most people get this view down the bottom right, grade 4 view. Yeah, I think it's in, doc. Yeah, got the tube in, you know. And then, you know, what do? So your SHO has popped the tube in and says, yeah, I think it went in. And this is what you get on the monitor. So in essence, an agonal rhythm, nothing, no signs of life. In any other practice, I would say to people, what would you want on there? What would you want next? Most people say, can we have end-tidal CO2? Well, that's just kind of missed neonatology by, really, to be honest. And this survey, so obviously after the NAP4 study, which is an adult anesthesia study looking at complications during airway management, I think people realized that capnography can make a really big difference. And I think it was implicated in something like 75% of patient events was if you had capnography, something better would have happened. So anyway, these guys decided to do a survey and find out which pediatric intensive care and neonatal intensive care areas had capnography available. They caused a bit of a stir, to be honest. I don't think the neonatologists were quite ready for it. So, I mean, most neonatologists probably think that CO2 detection is colour change devices, which actually I don't think are that good. And I don't think I'm colourblind, but I can't see the change if it's only 2 kilopascals. If it's a really low CO2, I can't even see its change colour. It's only really when it goes absolutely yellow that I realise it. So I think they're pretty crap. And also, there's all sorts of, when babies are born, there's all sorts of slime spurting out of their lungs and all that. And it just gets on these and just stops them working straight away. So obviously, the desired method is to have waveform capnography. So this paper, and there you go, here's this cardiac arrest patient now. They have an end-tidal CO2 of only 1.9, but I know the tube's in the right place. I mean, you know, so I'm slightly happier. I mean, obviously, this looks pretty futile at the moment, but at least I know I've got an ET tube in the right place. So what this survey did, this is obviously paper 2, they looked at PICU and said, how often, if you're doing a unit intubation, do you have waveform capnography available? They said, well, 100%. I said, well, what about if you're off the unit and you go to a cardiac arrest? Well, you know, 80%. But most of the time, you know, this dark green is the percentage of times you have capnography available, and the light green is, well, we're almost certainly going to have it, but not definitely. But the vast majority of patients being intubated by a PICU team, they have capnography available. Now you go to NICU, even on the neonatal unit, over 60%, there is no availability of waveform capnography. And if you go around the rest of the hospital, delivery suite, on all these cases I'm talking about, over 96%, there is no waveform capnography. So I suppose I'm asking you, why don't you go back to your department, see what the availability is, because you'll be caught one day and there's some uncertainty about, well, the child's not responding, so is my ET tube in the right place? And so having that really makes a big difference. Because that's how do you deal with this issue here? This issue is the patient is in an agonal rhythm, you're not getting any signs of life, and your end-tidal CO2 trace is flat. So I know what I would do if I was in adult medicine or pediatric medicine. I think I'd just I'd go to my difficult airway algorithm. And in fact, they just say, you'd be an ED, and they say, have a look at our resuscitation, our emergency airway draws. Now, I think most neonatologists look at it and go, holy, what do all these things mean, So I suppose my urge would be try and have some common language between anaesthesia, adult practice, paediatric practice, and neonatology. So this concept of plan A, plan B, plan C, plan D is not rocket science, but I think it does escape some parts of neonatology. So if you think about this, our plan A is try and put the ET tube in. If that doesn't work and it all fails, you go for supraglottic. If that doesn't work, you go back to bag valve mask. If that doesn't work, you say, well, the front of neck then. And all that stuff is possible in neonatology. And so this survey also looked to see how many neonatal units had even a difficult airway policy or a difficult airway trolley, and it's less than 50%. So I urge you, go back to your departments and just make sure if you're called to that type of patient, you have stuff available to you. I think my go-to airway when I'm unsure about whether an ET tube is in place, laryngeal masks are really useful piece of kit. And so if you're in your adult ED, if perimortem C-section's going on, and then suddenly Anita says, do you want to use a laryngeal mask? You might say, well, when I did my NLS training recently, and they don't talk about laryngeal masks, can I use them? This paper is a Cochrane review, which only just was reviewed in the last year, and it suggests that actually, if you compare laryngeal mask to either endotracheal intubation or to bag valve mask, which one's more effective? So bag valve mask, I think most people would say you have to be good at doing that if you're a neonatologist because you spend half your time going to deliveries doing that. Intubation, which I think people would have said was the cornerstone of secure airway, versus a laryngeal mask. And actually, the paper suggests, just very similar to adult medicine, very similar to the Airways 2 study, actually, that a laryngeal mask is just as, if not more effective than bag valve mask. You can very quickly establish ventilation. You can get a quicker ROSC rate. And it also is as good as a secure ET tube. So I think laryngeal masks are underused in neonatology. I'd urge you to make sure in your departments you have access to laryngeal masks. And I'm almost certain it will be the ILCOR guidance when it gets revised at the end of this year. So just have a think about that. Now, this is a sort of typical neonatal resuscitation. Loads of people stand around doing stuff, and they're all looking at something. So looking, what are they all looking at? Now, I would have thought they're looking at the end-tidal CO2. Well, I know they're not. Actually, they're looking at the clock, probably to do an APGAR, because that's what you have to do at 10 minutes. But 10 minutes is an important marker in neonatal resuscitation, especially in the newborn resuscitation. Because people are thinking, 10 minutes, no response. Oh, child's this is futile. And actually what I don't want is for the child to survive and have severe disability. These children here are all undergoing therapeutic hypothermia for birth asphyxia. And the newborn life support algorithm looks just like that. And most importantly, in the middle of it, it says, if the heart rate of a newly born baby is not detectable at 10 minutes, you can stop if you want. That's what it says. So this group, it's my paper 4, looked at the outcome measurements of those children at 10 minutes. If at 10 minutes, children who did not have, who were still in asystole, let's say, at 10 minutes. And I think in the past, self-fulfilling prophecy, because that thing said in the NLS guideline, at 10 minutes, if there's no heart rate, I think, well, I'll stop them. And then, of course, you stop and then they die, and then everyone asks you, what happens to your babies if at 10 minutes they're in asystole? I go, well, they all die. Well, of course they do, because I stopped resuscitating them. So it's a bit of a self-fulfilling prophecy. So these guys were brave enough to say, no, we're going to carry on a bit longer, And so they carried on. I think their average ROSC rate was closer to 22 minutes. And what they found, this is a survival graph so we look at the so this on the y-axis of this percentage, and it's clustered into 3 groups about gestation. So they found if you still didn't have a heart rate at 10 minutes, but ultimately carried on for more than 20, the term babies, over 50% survived. And if you look at the late preterms, 32 to 37, almost 50% of those survived. But of course, if you're premature, you didn't. I do a lot of adult cardiac arrests, and our survival rate's about 10%. So this is much, much better than adult cardiac arrests that we're going firing off to, Bosch 80-year-olds have, fallen over in Sainsbury's. So this is actually pretty good survival. So why would you stop at 10 minutes with this data? Well, I suppose you're going to say, well, that's because actually you're just keeping all these children alive, and they're going to be disabled. But actually, the disability data looks pretty good. 2/3 are okay. So should we stop resuscitating newborns at 10 minutes? Well, I have to say, I suppose that data is a bit worrying about the extremely preterm. I think we'd think about that. That'd be one where I'd be much more cautious. But even in that paper, they described how long it took to get IV access was on average 12 minutes. So if you stop at 10, you haven't even managed to get a UVC or a cannula in and give some drugs and stuff, yeah? And the therapies we have available now, a lot of that stuff was historical, and it was about there was no treatment. But over the last 10 or 15 years, therapeutic hypothermia has made a really big difference to outcome. So I think I wouldn't stop at 10 minutes. I just align it with all the other services. And in our minds, doing ALS or APLS, you go for 20 minutes, you can stop at 20, you can stop before if you want, but you're sort of thinking, I'm going to get to the 20-minute mark and then just find out what the rest of the team want. So I now would just advocate doing it for 20 minutes. Final part of this conundrum is, what would you do if it's a preterm baby? I've already said to chop this baby out if it's up to the umbilicus. Well, for a start, I'm very good at working out gestations. Ask these guys later, but I can't tell the difference between a 22 and a 21 and a 23. All look like that, all a bit jellified, really. So, and I'm not sure if any of you could really be able to tell me what the gestation was. What is changing, though, is this new draft document that I want you to have a think about. So we've had a pretty fixed guideline for the last 15 years of what babies we will resuscitate in the extremes of prematurity. The APM have just released this in the last couple of weeks, and it's a framework for what to do less than 27. And the major change in it, so I'll just go over what we do at the moment. So I would say, if someone said to me, I've got this woman, she's only 21 weeks pregnant, I'd say, we're not resuscitating that, mate. They say, she's 22 weeks, I say, not resuscitating that, mate. I'm not even going to go along. From 23, we'd start to say, okay, well, let's go and have a word with the parents then, because actually the outcome of 23 weeks is not great. I think we should try and put her off, But if they say, oh, it's a 20th attempt at IVF, please, doc, have a go, I'd think about it. And then once you get to up to 25 weeks, it's just routine to resuscitate them. So that's what framework, this Nuffield Council on Bioethics, been using this for the last 10 or 15 years, and it's worked really well. So the new proposal is that we will resuscitate anything from 22 weeks. And so I'll ask you, put the link on there, you can have a look at the data yourself, but this is the information that will be given to parents. So let's just focus on this 22, 23-week thing, because that is the tricky area. So at 22 weeks, the data we're going to be giving parents are that 30% survive, and if your baby does survive, a third of them will, we're not going to say that about your baby because that's individual stats. We're going to say if you had 100 babies born at 22 weeks, 30% would survive, and out of the survivors, a third of them would have disability, so severe disability. And I know, knowing how that, it depends on how you phrase this stuff, isn't it? But there'll be certainly a lot of parents who buy into this and would want you to resuscitate them at 22 weeks. A 23-week data is much better. All that counselling for the Nuffield bioethical was based on only 1% survive without disability. Now actually people are saying, look, you're going to have 40% are surviving, and only a quarter of them are going to have disability. So I'm sure there'll be lots more 23-weekers. I suppose the reason I say this to you, this is the whole data, the reason I say this is to you because I think, and they want us to do full resuscitation, by the way. So at the moment, I think you'd probably find people at 24 weeks would say, well, stick an ET tube down, but if that doesn't work, I'm not doing CPR, and I'm not sticking the adrenaline in. But actually, the framework says you should be doing full resuscitation. You either do it properly or don't do it at all. So that would be a big change for us as well. So look, why am I saying that to you? You guys are, so in neonatology, we could sit in our sort of nice little silo there, we pump out as many 22-weekers as we want, and maybe that's the right thing. But lots of us in this room have to then look after those children later, whether they're in PICU, whether they're in respiratory care, whether in community paediatrics. And I think this will have a big impact on the rest of the medical departments in the whole hospital. So this is your opportunity to feed back on that document. Again, it will be in the link. But that was my final paper. So thank you very much.
Thank you, James. I actually feel a little bit more reassured after that, especially when you talk about neonatal resuscitation as being a bit of fiddling around. So thank you. Some really important papers there, and I forgot to introduce the fourth most important person in the room after the three presenters. And Alice Munro is our Twitter moderator, so she'll be tweeting out the links, and she's also going to put them on the Trello page that Ian Lowens has set up as well. So have we got any questions that have come through on Twitter? Fab? Okay.
So thank you very much, James. That was especially helpful for me, coming from a purely EM background. We do have questions. We have people following not just in the room, but also in other rooms. But the question we have is from John Clark. He's asked us, how accurate is capnography in the extreme prem babies, given their tiny tidal volumes?
Yeah, so I think as accurate as... I work in adult medicine as well, and often the end tidal CO2 we have doesn't reflect what happens when you arrive in hospital and they do an arterial gas, but it's a very good trend. I think we have to work out what we're using end tidal for. If end tidal is purely being used as a method of identifying the ET tube is in the right hole, it works perfectly. even with 300-gram babies. I mean, all the patients we're moving on retrieval definitely have end tidal on to check it's there. I think like any patient that's got some shunting, intrapulmonary shunt, do trust that number. So it's a very good trend analysis, but I'm not necessarily saying I would always believe the number. We still do arterial gases on our adult patients with end tidal on. We still do that with neonates as well.
Thank you.
Any questions in the room? Yep. Hang on, I'll run down with walk fast because I don't run.
Just reflecting on the position paper that was about the survivability and intervention. In New Zealand, there's been an equivalent document produced in the last year, and there was a delineation made between born in a regional centre versus born in a tertiary neonatal hospital, and there was a big distinction made in that the survival out of a big centre is very, very poor. And I'm just wondering if the British document has alluded to that at all, or whether it's saying you should be attempting this resuscitation regardless of the centre that you're born into?
Yeah, I've really massively simplified the documents. I think it's good to look at it. What they're asking you to do is, at each gestation, is start with those figures, that parent information figures. But what you're meant to do is to think what's good, what's bad. So so many of the patients who end up being born in a local centre, it's probably because they just walked in the door and delivered. So what you're meant to do is start with your starting figure and say, is there any modulators here? So for example, walks in the door, no steroids, no magnesium. You go, oh dear, I'm going to be more cautious with that. And they say, actually, they're towards the end of the 22nd week, not the beginning of it. Oh, okay, that's a bit better then. And then you say, mum's got sepsis. Oh dear, okay, that's yeah. And then, what sex is the baby? Okay, you go this way or you go that way. And so what they're asking you to do is to shift backwards and forwards depending on increased information. So that would definitely be relevant. So the document definitely says centralise all of them, make sure they're in the tertiary centre. But when you can't do that for obstetric reasons, whether there's, I don't know, the umbilical cord hanging out or she's already 10 centimetres dilated, membranes ruptured, you can't move those. But similarly, they are also the group that are very unlikely to have decent steroids on board and magnesium, and they all almost certainly are at much, much, much higher risk.
Thank you. Any more questions in the room?
So with that new data, is that going to be like spread through our obstetric colleagues as well? Because I've worked in places where it's very, very difficult in a district general setting, and obviously their priority is the mum and the baby, and what they think is very difficult to transfer out. And my argument is that actually some of them it's even more difficult to transfer a 22-weeker. And I don't live somewhere where it's like several hours away from anywhere, like it's literally half an hour down the road. Is this data going to go to our obstetric colleagues to get them to think a bit more reasonably about transferring at an adequate time?
So this is a consultation document. It's out for every department to comment on. I suppose my disappointment is maybe last time the Nuffield Bioethical Council thing involved everyone, from ex-patients to parents to the clergy to firefighters to everyone had a say in it. At the moment, the BAPM is obviously they've nominated a group that are going to write this guideline, and it perhaps, and of course there are obstetricians on that, but I don't think there's been as much wider stakeholder involvement as usual. So this is your opportunity. So I'm urging you to get your obstetrics in your local department and say, read this proposal, because if this happens, this is going to happen, So put your comments down now.
Thank you. Any more questions in the room? Okay. Anything else from Twitter, Alice? Any comments or questions?
Not yet at the moment.
Okay.
Everyone just says it's really great.
It was really great. Thank you very much,
Cheers,
James.
thank you.
Thank you.